The objectives of this talk are to describe the evolution of thinking that led to the approval of the US FDA's approval of the first over-the-counter home use rapid HIV test, otherwise known as an HIV self-test. I had the privilege while I was at the FDA to be leading the group that was responsible for the approval of this test, and working on that since 2005, and so feel partially responsible for what's going on here. Also to appreciate the flexibility that can or should actually be exercised to meet a critical public health need. So let me just start with some commentary on regulation, assessing the HIV self-test. Assessment involves looking at two things: quality and performance. The purpose of looking at quality is for consistency. The bottom line here is that if you can't trust the test, you can't trust the testing. That's a basic pillar, and that's about 5 talks that go through that. I'm not going to talk about it anymore. I am going to talk about performance. And the question here is, or the issue is, that regulators usually looking to see that the test is performing at as high a possible level, highest level as possible. But I put a question mark on that, and you'll see why in just a few minutes. Another important point to mention here is the reality is that no test is 100% sensitive and 100% specific. If a manufacturer comes to you with such a claim, you should have a lot of questions about that. It simply doesn't exist. What you are looking for is that the benefits outweigh the risks, and that's going to be the theme that I'm going to carry through this talk. So let me go through what the FDA did as far as the approval of an HIV self-test. And I just want to mention that Alwyn's data is remarkably similar to what was seen in the US, and I'm actually very encouraged and, I don't know, not frightened, but it's spooky the way that the numbers are similar. So let me set this up by telling you why an HIV self-test was considered for the US. So the number of Americans newly diagnosed with HIV infection each year is about 50,000. The number of HIV-infected people in the US is 1.2 million, and the number of people who are infected with HIV and don't know it is about 1 in 5. So about 20% of people in the US at the time of the consideration of this didn't know that they were infected with HIV. That's a serious public health issue. So the test, of course, I'm going to be talking about is the OraQuick in-home HIV test system. This is exactly the same test, well, pretty much the same test that is being used here. Notice that the packaging is slightly different. Of course, the instructions are different, but the actual device is the same, other than the fact that they are manufactured in 2 different places. So the expected performance of the professional use test, and by the way, the self-test is also exactly the same as the professional use test. Traditionally, FDA has expected sensitivity and specificity to be at least 98% as the lower bound of the 95% confidence interval. For a self-test, an advisory committee recommended that sensitivity and specificity be dropped, acceptable sensitivity and specificity, be dropped to at least 95% rather than 98% as the lower bound of the 95% confidence interval. Why? Because there was an expected decrease in performance in the hands of non-professionals. So the traditional way of dealing with this as a regulator is that if you're going to look at test performance and then determine if that performance is good enough to say that this test is safe and effective. It's a straight line. Let me show you some results. So here's the professional test performance for the OraQuick test. What I'm showing you here is specificity and sensitivity, and the second column over is performance of the professional use test. And the last column is what the expectation is, again, 98% as the lower bound of the 95% confidence interval. You can see that the specificity of the professional use test was 99.6 at that lower bound, and the sensitivity was 98.4. It just made it, again, for professional use. Here are the data from the testing that was done in support of the home test. And what you can see is that the specificity is phenomenal. It was supposed to be at least 95%. It was actually 99.9% in the clinical studies that were done to support this approval. However, when we look at the sensitivity, the expectation, again, 95%, it turned out that the lower bound was 86.64%. Again, the number is remarkably similar to what Alwyn was talking about, which means that this may be the maximum capability of this test for use with oral fluid. That's for another study. So the question here is, what is a regulatory agency to do with data like this? Two choices. One is, the obvious one is, hello, OraSure, go back and redesign your test because you're just not good enough. It has to be at least 95% at that lower bound. So instead of looking at the straight line, what FDA actually decided to do was to take a different route, and that is to say, okay, what are we getting for performance like this? And we would get to that through a risk analysis, which looks at the public and individual health implications, and then make a decision on safety and effectiveness based on what that lower sensitivity will give you. And that's what I'm going to show you right now. So FDA generated a risk model, and the inputs into that model were the estimated test results for the number of people who would be tested annually who wouldn't otherwise be tested in that first year of use. And looking at true positive results and false negative results, as well as true negative results and false positive results. The output from the model would be the estimated net transmissions, which would be averted in the first year of use, the impact of switching from professional testing to self-testing, recognizing that if a self-test were available, people would use it instead of going to get professional testing, and the public health implications and individual health implications for a test that would perform at that level. So let's talk first about the projected outcomes of testing in that first year. Here are the numbers based on the model. 42,000 true positives would be expected from those people who wouldn't ordinarily be tested. 7,000 false negatives would result. There would be 2.7 million people who had true negative results and 3,600 false positives. To put other numbers on this, there would be a ratio of 6 true positives for every newly identified people for every false negative result, versus a professional use test, which would yield 62 previously unidentified infections for each false negative result, a difference of about 10-fold. On the specificity side, it's really not even worth talking about because the specificity is so high. In fact, the specificity appeared to be even better than professional use. Next piece here is the projected net transmissions averted. And what I'm showing you here is there would be about 4,000 to 4,500 transmissions that would be averted as a result of using a test that performed, that had a sensitivity at that particular level. And it's important to note here that what I'm showing you here on the y-axis is the percent of people who are switching from professional use testing to home use testing. This is just a projection, anywhere from 10% people switching to home testing to 100% people switching. And even going from, if you have everybody switching to home testing, there would only be about 300 fewer transmissions averted if the current users of professional tests switch to the home test. Okay? So, the summary of the assessment is that on the basis of this risk model, FDA projected a net public health benefit to the OraQuick in-home HIV test, and that would be in the form of a net increase in the number of HIV infections newly identified in the first year, and the number of transmissions that would be averted in that first year. Keep in mind, this is a value judgment. There are no hard and fast ways to say whether something is acceptable or not acceptable. But this was what the our advisory committee had recommended, that there was enough of a public health benefit to actually approve the test that was performing at that level. At the same time, you have to admit that there is a certain amount of risk, and that would be in the form of increased numbers of false negative results. So what FDA did was, as it usually does, is to say there is risk and to try to mitigate it. How was that done? It was through a series of messaging. I want to point out here that the graphics you're going to see are graphics that I inserted. They did not go into the package insert. So the first message is that a positive result doesn't necessarily mean that you're infected. You have to follow it up with supplemental testing. Second message is a negative result doesn't necessarily mean you're not infected. Because especially if your exposure has been within the previous 3 months, which is the window period for this test. Next message is retesting is recommended if you test negative, and continue to engage in behavior that puts you at risk for HIV infection. And finally, a negative result doesn't mean it's safe to engage in risk behavior for HIV infection. So earlier there were some questions around imperfect tests and how you actually communicate with people. It's very, very important that people who are using an HIV self-test know what the limitations of that test are. What this does is a couple of things. It empowers people to take to test themselves, but at the same time, it tells people who are using the test that they too have a certain level of responsibility, and that they have to understand that this test is not going to be effective within the window period, for example. People need to follow, to pay very close attention to the messages that accompany, that communicate rather the risk. So, where do we take this in terms of STAR? Does the modeling that was done at the FDA apply to STAR? Well, the technique does, yes. But the numbers don't necessarily transfer because the assumptions that are being made that go into the inputs to the model and the outputs of the model are likely very different. But the concept here, I think, is the same. Let's see, I just said that. The challenges that remain are where do you draw the line between acceptable and not acceptable? I mentioned earlier that there are no hard and fast rules for the number of false negatives that you're willing to accept. It is a value judgment, and that takes some extensive discussion, and then some conclusions need to be made on the value of this test, because if you admit that there are people who will simply not be tested unless they have a self-test, that needs to be taken into account. Monitoring is also necessary to determine if the right choices were made. And let me just finish here with some concluding messages. Be flexible to meet a defined public health need. Be rational in your decision making. Considering the benefits and the risks can actually take you in some directions you really didn't expect. And sometimes what's expected is actually a good thing. Finally, be willing to accept risks, but also at the same time acknowledge them and mitigate them as much as possible. Thank you very much.